Everyone, this is Dr. David Spiro, professor of pediatric emergency medicine at Arkansas Children's and University of Arkansas Medical Sciences. And this is Human Medicine. This is a podcast about how we all are human and how humanity affects us as physicians. And really, it's also just about all the crazy stories that we have and how we process them. And part of medicine's journey is I get to meet some really cool people along the way. And this is the first time I've had an opportunity to see a colleague of mine that I haven't worked with in over a decade, and his name is Dr. Zane Horowitz, and I'm incredibly honored to have him here on the show. So, Zane, thank you for joining today.
Yeah. Oh, thanks, Dave. It's great to get back in touch and see you after all this time.
Yeah. So I would love to, we usually start the show by talking a little bit about how you got here today, where you started your journey, and what you're doing now in healthcare.
So let me start with the last of that. I'm doing what I've been doing for a very long time now, which is now it's technically the associate medical director, was the medical director of the Oregon Poison Center. Over the years, we've covered Oregon, we've cross-covered Washington, Utah, Alaska. We still cover Guam. Very interesting out there, but we take calls and we do bedside consults and we teach residents and we have a fellowship. So very engaged in academics and teaching, and still doing all that. I'm also an emergency physician, had been doing that for close to 40 years. I've tapered that down over the last few years and actually is pretty much now just only work in toxicology.
How did you get here? Where did you go to medical school, and how did you end up in Oregon? I believe we were just talking about this. You're originally from Southern California. Is that correct?
Well, Sacramento, technically.
Sacramento.
So originally, I'm from way back east in New York and Long Island. Went to school in upstate and came out to do my internship in the Central Valley at UC Davis at the time, which was a county medical center when I was doing that, and hence the title of of the book that I wrote, which is a novel of that period called The County. I spent internship there, residency there, went away to do emergency medicine, came back again to do faculty for 17 years at UC Davis, and then I came up to Oregon where we crossed paths, where I was on faculty at Oregon
What
Health.
year did you come to Oregon Health and Science University?
I got here in 1997, so it's been
Wow.
20-something years, 17 years there and 27 years here. So I'll let you do the math on that. It's been a while.
Wow.
Trip.
That's quite a journey. And real quickly, before we get into the story, can you let folks know a little bit about what the job is and what you do as medical director of a poison control center?
So the Poison Center receives calls from the general public, moms and dads. Mostly, actually, our call volume is pediatrics. I'd like to say 60+% of it. Children getting into something around the home, the mom or dad or babysitter or school calls, and we'll find out what it is and how likely it is that they got it and how risky it is as a substance. And it's not just pharmaceuticals. Sometimes it's plants. Sometimes it's a household cleanser or product. And we do an assessment. Both nurses and pharmacists are on our primary intake team, and we figure out, can we watch them at home? And often the answer is yes. Sometimes we need to send them to the hospital, and we try to choose the most appropriate hospital. Some substances are quite serious, like if child ate like 4 or 5 pills of a highly potent calcium channel blocker, we want to get them into a place they have critical care services. Where someone just took something that we think going to be watched for maybe 6 to 8 hours, we probably say the local emergency room is probably a good place to start to get evaluated. And we do bedside consults here at the hospital as well. I would say more than half of our consults are pediatric. that kind of fall into two groups. One is adolescents, and actually that number has been creeping downward to like the 10 and 12-year-old range, which are not technically adolescents. Having some crisis in their lives and ingesting either something that's around the house or medications that belong to them or medications that belong to someone else in the household. And we need to watch them. And some of them, some of them are can be quite serious because these are larger ingestions than the other group, which tends to be a toddler, preschool age child who's exploring the world with their hands and putting things in their mouth, and tend to take large amounts of substances, but sometimes even a small amount of a critical pharmaceutical can be very risky. So we see both of those, and we see adults, of course, and then we do a lot of environmental things. There's plant exposures, snake bites, food poisoning, marine envenomations, a whole kind of bunch of things.
I actually admire so much the work that you do because, as a non-toxicologist in pediatric emergency medicine, we see all of these things, and it feels like it's just an enormous amount of knowledge to figure out what to do, because there are so many things that children get into, whether it's prescription medication, non-prescription medication, other substances, and um, it's just a fascinating field. So thank you for sharing with us how you got here and what you're doing. Would love to hear a little bit about the story. You're now an author, which did not happen when I was with you, and I would love to know a little bit about your book and the story around your book and how it sort of came about, and you had the passion and inspiration to do it.
Well, I mean, the real inkling of it all probably started way back in internship, and the book, is called The County, and it takes place in internship. It's not a memoir because I think my personal story may not be all that exciting to read about, but it's a, a put together story, mostly following four interns from very different, diverse backgrounds, struggling through, I think, what most physicians will appreciate is probably the both the toughest and most educational year of their lives, struggling with learning new things, taking on new responsibilities. Add to it the added stresses of working in a place that's underfunded. And remember, I got to set the scene. This is 1970s when this happened. There weren't attendings signing off on every case. There wasn't CT scanners down the hall. There wasn't trauma teams, stroke teams, cath labs. All these things were yet to be,
So
solidified.
let's talk about that in 1970. So right now, so the audience knows, if Dr. Horowitz or I am in the emergency department, we may have 2 or 3 levels of learners that will see the patient, but ultimately, uh, in almost every Zane, correct me if I'm wrong, but in almost every academic center that I'm aware of, ultimately the attending, who's someone who's board certified in that specialty, will ultimately see the patient. They may not be the first person to see the patient, but they may see the patient. And can you describe for us a little bit about what was happening in 1970 if you were an intern and you had just finished 4 years of medical school?
Yeah. Well, I think it's real important to understand the history of how emergency medicine evolved, way before it was ever a specialty. The book actually follows like the four interns who are actually internal medicine interns who work in a place where everybody has to rotate through the emergency department. And it's not just internal medicine, it's everybody. They're relatively, I would say, lightly supervised. There's always like someone who's like an R2 or an R3 hovering around to get some
That's someone that's in their second or third year of
second or
training.
third year of
Yeah.
training. There's one attending out there somewhere who's got a loose knowledge of what's happening, but they're basically in this era of time, in this important era in the late 1970s, pretty much told to see patients, present patients, make decisions, kind of do things on your own within the limits of, quote, what you feel comfortable doing. And people, I think back then and similarly now, kind of want to show that they're independent and have clinical decision capability and sometimes push themselves um, into a situation where they probably stepped a little bit too far. But the good news is there are higher level residents to help them and faculty to help them as well. Um, and back then, internal medicine doctors they saw pediatrics, they saw ortho, they saw GYN, they saw a little bit of trauma. The surgeons always came thundering down for those, but um, even before there were trauma centers, but pretty much it was anything goes. The shifts were 24 hours long, something I think nowadays would be incredible. And then, they rotated elsewhere in the hospital too. They worked in the ICUs, which were a shadow of our current knowledge as ICUs. The ICU described in the book are essentially three adjacent rooms that were turned into an ICU by knocking down the separation between them. So they were squeezed three people into a double patient room and made a 9-bed ICU in the early days of as this was evolving. And again, it was a relatively underfunded county hospital, not with all the bells and whistles of an ICU that we kind of envision today.
So when you were in training, was emergency medicine, at the time that this book is described, or even when you were in training, were there emergency medicine physicians? Was emergency when did emergency medicine become its own specialty in training?
So not till I would say 6 to 8 years after the time period of this book, there was a lot of people who were doing emergency medicine. And I mean, they were characterized as both cowboys and misfits and people who couldn't find their place elsewhere in the world. And that was generally not true. I think there were people who really liked that environment, like that pace and like that being on the spot and helping people. And they formed sort of the early gel of who the emergency physicians in the world were. Um, the bulk of the House of Medicine, the House of Surgery, fought very hard to prevent emergency medicine from becoming a specialty for several years before finally it was voted to allow it to become a specialty of its own,
Interesting.
give
Yeah,
board exams, and potentially progress to where it is today. So I think for those of us going into it now, medical students and residents, I think it's critical to understand where this all started.
absolutely. So what's interesting is I don't know if you recall, but I was a pediatrician on the coast of Oregon in Newport, which is central coast of Oregon, for 5 years, and I worked in a small town with a 4-bed
Mhm.
emergency department. It used to be called Pacific Communities Hospital, and when I was there, it was staffed 24/7 by family doctors and internal medicine doctors. And I remember in 1998, maybe 1999, we got our first emergency medicine boarded physician in the county. And so it's, I think history, your book and history is so important to think about. But prior to this 80s and late 70s, really emergency medicine as it exists now didn't exist. It was a collection of things, but it didn't exist in an organized way like it does now.
And even like you say, as late as like the mid to late 90s and more rural parts of the country, it was the same sort of notion.
Yeah. So let me ask you this. I didn't practice medicine. I didn't start practicing medicine or have awareness of medicine until the late 80s, and that was in San Francisco, which is a whole other story. We'll talk about at some other juncture. But what do you think the care was like for the patients back then versus the care that they receive now? Obviously, technology was different. So you had mentioned there were no CT scanners, but what was the care like as a patient versus the care folks receive now?
Um, I think patients got good care, and I think people tried hard, and we had other things that we had to use that now seem even completely archaic or unheard of to the medical practitioners of today. Um, instead of trauma cases, a lot of them got peritoneal lavage, which is still used in remote places because there was no CT scanner to take patients to. I had done, I would literally say close to 100 of them or more, where, you came in with a tender abdomen and you have to slink a needle in, fill their abdomen up with some fluid, then put the fluid down on the ground and see what drained out. If it was bloody, and as the expression went, if you could read through the tube, it was okay. But if it was too pink to read through, they were probably bleeding internally and needed a trip to the OR. We didn't know what was bleeding internally, but something that needed to be fixed by a surgeon needed to go. Um, we didn't have ultrasound at the bedside. We had to use our clinical judgment for a lot of things. We percussed a lot of things out. We figured out where abscesses were and whether a leg was tender enough that we thought they had a DVT to go further. So a lot of things have changed. Um, I think we did what we knew was a good job at the time, but sure, I appreciate the rapid developments. Having a bedside test that can give me an answer, or a CT scan, which I'll be the first to admit, I think has maybe we got a little over exuberant dependently on CTs for many things,
Yeah.
but they definitely were advances, and the fact that they were near the ER. There's a small vignette in the book where they want to get a CT on a person, but it's actually in the next building away, and they got to
Mhm.
take the patient down through an elevator, through the subterranean piping and venting and AC uh, ducts to the hospital and bring them up into this other building. And then all of a sudden, the internal sent him over. Here's overhead code blue, outpatient radiology. And he turns to his senior resident and go, "Is that something we have to go to?" And he goes, "Yeah." And they all go running through the hall, the ducts in the sub basement. And they come up there, and there's like the worst place you'll ever want to run a code on somebody is in the radiology suite. And there's the techs scared out of their mind, and nobody else is showing up. And then they resuscitate the patient in a scenario. And then they go, "How do we get them back?" And the X-ray tech goes, "Well, we're not considered part of the hospital. Our rules are you have to call an ambulance to bring them back to the hospital." And, the sort of the main protagonist of the book goes, "No, we're not doing that." And they roll back through the basement and the sub basement and bring them back to the, to the hospital, to the emergency room with essentially a good outcome. But,
So do you think, if you think back, look about in your career and the interns in this book, um, was the training better back then? Were folks trained at the end of their residency to be better doctors than they are now, or is just the technology is different and the skills that are needed are different now with the newer trainees?
I think there was a lot more sort of fine-tuned, nuanced clinical judgment that went on because we weren't so technology dependent. So that was good. We had to kind of get a good history. There were a bunch of things like X-ray findings that might suggest a pulmonary embolism, where now we go, well, I think it's a pulmonary embolism, just going to go ahead and do a CT scan. But then we used to look for Westermarck sign and all this other stuff. Um, but uh, but the other part of things is, I think, and another theme in the book was that we really worked poor interns and the residents to the edge of their tolerance and probably beyond in many points. There were 24-hour shifts sometimes on wards, so it was 36 hours. There was no option to say, I'm feeling fatigued, I'm feeling tired, I can't function. I just had a terrible crisis with a patient room. I need a minute to take a break. It was like, you know, straighten up, throw some water on your face. There's people to be seen. There wasn't sort of that outlet to reflect and discuss and decompress. Um, and the time crunch was there. There wasn't caps on how many patients could be admitted. There wasn't caps on how many patients were coming through the door. Um, and so it was a lot more, I think it was a lot more stressful, although there's new stresses now, of course. Um, I think the things that saved people then and should be available to save people now was the camaraderie and the mentorship of the person who had just been through what you've been through a year or two before, talking to them in the moment, saying, what do you do in this situation? How do I deal with this roadblock that I'm facing? Or I'm feeling horrible because the patient had an incredibly bad outcome and I feel responsible for it. And how do you get over that? And this is years before anyone ever had the term PTSD or burnout or anything like that. It was just the expectation was there to just continue to go forward. Um, I'm not sure that was 100% better, but it was there.
Yeah, it's interesting. I feel like some of our newer learners are very uh, easily distracted and oftentimes less detail oriented, especially around history taking, which I still think is an art.
Mhm.
And we discussed on another episode that 90% of the time we can make a diagnosis just on the history of alone. That's been evidence based, proven, especially in the field of pediatrics. So I want to quickly turn to the book. We do different things in academic medicine. We teach. You have a big administrative position as a leader in pharmacology, toxicology in multiple states, even in Guam. So we do lots of things where we wear lots of different hats. What inspired you to write a book? Because to me, to write a book, you have to be passionate about something to spend what I'm guessing hundreds, if not thousands of hours on a piece of work.
Yeah.
What inspired you?
No, I think there were phases which accelerated, a few years ago. I had written little snippets of the people we'd talk with each other, sort of that camaraderie and mentorship. I'd write down like a little bit of a story or an interesting case. And I was always writing up case reports, which is essentially telling stories of what happened to a patient and how an outcome. But I was doing it more for, the emotional impact on both the patient and the doctors, which is, I think, the focus of the book. How do you get through this year of incredible high stress and high um, number of hours that you're working? I put it aside. Life happens. I got a job. I worked there. I moved up here. And it wasn't until COVID happened and well, we were spending a lot of time in isolation and people were saying, oh, you should do some journaling to kind of, and it was like, oh, what am I going to write about? It's like I'm sitting here and I wish I was at work more or at work and everybody's really sick. And, so I picked up some of the old notes and started to not so much tell my story, but create a multi-character who interact with each other in a lot of different ways tale. And so it is clearly a novel. It takes place in a place called Central City, California, which is, a thin disguise for Sacramento. Um, and it just tells the story of having how to get through this era. Some people face tremendous self-doubts. Main protagonist starts out as an internal medicine physician and slowly kind of with the mentorship of a far thinking, leader, teacher, sees that emergency medicine may be something of the future. It may be, we need someone in the emergency room who just does emergency medicine, stabilizes the critically ill, who deals with the ambulances, who coordinates all this stuff and not anywhere else, and so his evolution is he goes from this, I'm not sure if I want to follow the persuasive wisdom of the day, which is just learn a little bit about everything and go and work in an office versus the work in emergency medicine, this essentially at the time unnamed specialty that didn't exist.
Yeah, and back then, it was called the emergency room.
It was. It was.
And because at one point, I believe this is true back in the 40s, and the reason why I know this is I worked in Romania in 1993. And in Romania in 1993, it was a, it had just, the walls had broken down and medicine in Romania was sort of frozen for 30, 40 years since World War II. And they had an emergency room where you would go,
Mhm.
and maybe there was an emergency treated there, but it was a room, and that was in a place for admittance into the hospital. And I'm curious when what your experience is around emergency room, and now it's called an emergency department.
Yeah, there was sort of this big like linguistic change. We always called it the emergency room or the ER, and I had worked in a couple of places that were literally, as you describe them, 3 and 4 bed gurneys that were a single room, no bigger than like the kitchen I'm sitting in right now, in community hospitals. Um, the university at the time, or the county at the time, was not that. They had about 8 different rooms of different sizes. They all different capacity of folks, but we still called it the emergency room throughout my entire time there. And everybody else in the hospital did too. Even after we sort of wanted to say we were a department, we were going to be equal to everybody else. Nobody else was calling us the emergency department. Everybody else was calling us the emergency room, probably another decade or more before it finally caught on, throughout the hospital.
So, were there any challenges or barriers for you to write the book, and were there any sort of emotional ups and downs that you experienced in writing the book? Because to me, writing a book seems like a far off, almost impossible task, and I'm just curious, what is this the first book you've written, and if so, how did you approach it?
Yeah, I mean, I wrote it. I mean, they always say the first draft is, you're just like get it down and get the story down on paper, and then really the hard part of writing a book is all the editing that needs to go into it. You reread it, you go, this doesn't make sense, or this thing's out of place. And one of the things someone told me is like, whenever you write dialogue, and you're re-reviewing it, is like say it out loud. Does it sound true to what that person would say, or is it like something stuffy and nonsensical? The book went through 2 editors and about 8 revisions, so that took about 2 years after I got that first draft down on my computer. And there were a lot of times I thought that I'm not going to really do anything with this, other than it was a fun exercise to do. COVID's ending, till I'll go back to work, but I kind of stuck with it and eventually um, got it to publication. It's paperback and Kindle versions only, um, but it took a long time.
Awesome. Well, that's that's an incredible story. So what if you had to talk a little bit about the one or two things that folks are going to get out of reading the book? What do you think? Because we have a lot of early learners. I can't wait to read the book. I wish I did before we went on air today, but I want to read it. So what can you tell? What are the takeaways, or what sort of things would someone learn from reading the county?
Well, I think it's kind of two aspects. One of it, it's sort of a historical representation of what medicine, and specifically the evolution of emergency medicine, was in the late 70s up into for 1980 or so, and how vastly different medicine is. And I think every one of us, and I mention this when I teach all the time, it's like things we're teaching you to do today, your decisions you're going to make today, you will look back at the end of hopefully a very long career and say, I can't believe we were doing that. This was we were given this medication for that reason? That makes no sense. Um, and there's a lot of that in there.
Mm,
But the other thing is, I think it's just there's this intense rite of passage of internship that hasn't changed over the last half century, essentially, where you are suddenly thrown out with an incredible responsibility at a reasonably young and sometimes inexperienced age, with lack of direction, sometimes hard to find guidance. And I think the glue that holds you together and gets you to survive that is your camaraderie with your other interns, and hopefully finding a mentor, gelling with somebody you work with that you go, "Well, this person gives me good advice all the time. And so I need to sit down and, decompress. This is the person I need to find and go with." And I think that's the message for everyone. If you're as a medical student listening to this now, um, you know, don't artificially get assigned a mentor. Find someone you really like, and you can talk to at 3 in the morning when things finally get quiet, whether it's the emergency room or the ward of the ICU, and be that person's uh, friend for many, many years to come.
Well, Zane, it is great reconnecting with you. Oregon is lucky to have you, and the whole region in the Northwest and Guam is lucky to have you in your leadership position. And one of the reasons why I love medicine, I would do it again, over and over again, is to meet people like you, who we might call a mensch, who is a mentor and a friend and always doing the right thing. And I've sought advice from you, and I think this is great reconnecting and getting folks to hear a little bit about your story. So thank you for joining us. So, folks, thank you for listening to HuMed. This is Dr. David Spiro. Please subscribe on YouTube, Spotify, wherever you listen to your podcasts, and we will include information about Dr. Horowitz's book and how to access it on Amazon. And Zane, thanks for writing the book, and thanks for joining us today.
Oh, thanks, Dave. It's been a thrill just kind of doing this and talking again.
Thanks for listening to HuMed with David Spiro, MD. If you like this episode, make sure you're subscribed on Spotify, Apple, or your favorite podcast platform. The video versions are also available on YouTube. Make sure you subscribe and hit the bell there so that you never miss a future episode.